Typically, we'd see an ACL repair with or without meniscus damage in the first sort of 10 to 14 days, depending on the surgeon, but that's generally around when they'll be in for their first session. The surgeon will often give the patient a little paper, A4 paper with 2 or 3 things to do, which can be valuable in the first couple of days, but really the first 7 to 10 days, similar to my experience, it's very much pain control, it's very much keep the swelling down. An angry, swollen, hot knee is usually a painful knee. That's the focus in the early days, pain control, keeping it up. And so we're happy to guide people, and we'll often be on the phone and emailing advice and guiding people through that initial phase and reassuring them that it's a normal part of the recovery and there are a few things to look out for that would require maybe medical attention. But yeah, early days, very much pain control. Day 10 to 14 is a lot of education around what the next few months are going to look like. An ACL repair's a little bit more complex than a sprained ankle. So people will be coming in for a good chunk of time, and people will be rehabbing, and people really need to buy into a good length of time of rehab, of sustaining rehab. It's not a walk in the park. So getting them through the first sort of 4 to 6 weeks and really focusing on a fully locked out straight knee and a fully extended knee is important post-op. And just keeping an eye on the amount of flexion and bend someone has in the knee is crucial. We're obviously looking at the wound and making sure that looks all really nice. The amount of swelling guides us a lot as well in terms of how the patient is tracking. Most commonly, the ACL repair patient will have a wound review with the doctor surgery or the surgeon in the first fortnight, and then usually a review at 6 and 12 weeks. The 12 weeks is a big one because the surgeon really wants to see a fully extended knee, a healthy amount of bend, some quad control starting to come back, and a really healthy scar. So if you tick all those boxes by 12 weeks, you're on track for a pretty solid return to function, sport, work, whatever that looks like. Over the last couple of months, we've had a few interesting shoulders. One, I've got to be careful not to be too specific here, but one is an athlete, a professional athlete, who dislocated a shoulder in the middle of his training for an upcoming Commonwealth Games, which is a really interesting one actually. So said individual qualified after dislocating his shoulder a couple of times. So that for us is, particularly considering the context of that particular situation, time is quite crucial. We don't have a lot of time. We've got 6 or 7 months to come games. So we are MRIing straight away because we want the best quality picture in the shortest possible time, and we're straight in for orthopedic review with one. So that's one example of, it's a very unique presentation, but someone who doesn't have time on their hands, someone who needs full function of their shoulder tomorrow. Interestingly, it's not uncommon with the dislocators, particularly the first time dislocators. Movement's actually not a problem, even in the acute phase. They can be uncomfortable, they can have trouble sleeping at night in the first few days, but their biggest issue is the instability that's come secondary to the trauma and the dislocation. So this particular dislocation was an anterior dislocation with some labrum damage and some bone damage and some rotator cuff damage. So there's a bit going on in there structurally. We're going to be guided by the orthopedic specialist around what the best path is for this particular individual with their specific circumstances and specific context in mind. So having the priority for us really is to not so much spend time here, is to make the clinical decision that this is something that needs to go further, get the MRI straight away, get in with the orthopedic surgeon straight away, which we can expedite for people. And we're certainly guiding this individual, this athlete, around what they can be doing while they're waiting for the ortho review. But that'd be an interesting one to sort of see how it plays out. But that's one, like a traumatic injury pathway. Another interesting one over the last month anyway, a rotator cuff repair in probably mid-60-year-old female. And this is not a super uncommon occurrence, but fall on an outstretched hand, rotator cuff tear, pain, movement restriction, quite a bit of pain. This one was a little bit complex because in the months subsequent, the particular lady struggled with and seemed to develop frozen shoulder. So she had the background of the trauma fall onto the hand, the rotator cuff there, so the structural damage to some of the really important tendons in the shoulder, and then a frozen shoulder, so a sharp increase in pain and marked reduction in range of motion. So the lady was pretty distressed. If we fast forward a few months, we sorted the frozen, so some orthopedic intervention, sports physician intervention. Hydrodilatation was the selected best method, which is an injection into the shoulder, basically that increases the movement at the capsule, which is one of the major restrictions with the frozen shoulder. So got a movement back, then addressed the rotator cuff with surgical repair. That was the chosen method, or that was the advice from the particular orthopedic surgeon at the time. So function was still quite poor. So that was the pathway that we went down with this lady. Not a great, she did everything perfectly, attended her rehab and did her physio, and she was the model patient. And unfortunately for this particular patient, the cuff repair was a failure. So not because of a trauma or an action in the post-operative phase, but it was just a failure. So she is in line now for what tends to be the next phase, is that there's no repeat rotator cuff repair. The next phase is really a reverse shoulder replacement, which is nasty, but we'll be supporting the lady throughout it. But that's a really good example, not a good example, but it's an example of when things don't go perfectly, despite the patient doing everything right. So yeah, she'll be most likely having a reverse shoulder replacement in the next 3 months. The reverse, the orthopedic surgeons, I'm not an orthopedic surgeon, but the orthos, just from my experience, tend to go reverse shoulder replacement when the cuff is insufficient. So when we haven't got enough tendons and beautiful muscles in our shoulder to keep the prosthesis of the shoulder replacement nice and snug and tight, they'll go to reverse replacement, which is basically swapping the ball and socket around. So